morning, honorable members, and good morning, our stakeholder. Welcome to today's engagement. Today is a continuation of the inquiry that we've been having since Monday this week. And today we are interfacing with officials from the Ministry of Health, Parliamentary and Nurses Council. Before we go into the details of our discussions, may I ask honorable members to introduce themselves, starting with a member from that far corner, please.
Thank you so much, Chair. My name is Morris Harrison Chikafa, representing the people of Dedza Dranyama constituency. Thank you, Chair.
Thank you, Chair. Through you. Good morning. Dr. Fale Simpo Hamoyo, representing the people of Chitipa North constituency. Thank you.
Through the Chair, I am Mwisho Alexander Chiribuntima, representing the people of Ncheu Central East, and I'm a member of this committee. Thank you.
Good morning, Honorable Chair. I'm Deus Gumba. I come from Chinji Southwest constituency. Thank you.
Morning, Chair. My name is James Mpunga. I represent the people of Zomba City South constituency.
Good morning, Chair. Through you, my name is Right Reverend Alex Mahoe, representing people of Mzimba Sorola, and I'm a member of this committee. Thank you.
Good morning, Chair. I'm Jeremiah Jumbe, representing the people of Blantyre Southeast constituency.
Good morning, Chair, and everyone in the House. My name is Skefa Mlongoti Chimoto Piri, representing the people of Nkota Kota Mkula constituency. Thank you.
Good morning, Chair. My name is Urunji Kani Nyirenda, representing the people of Mzimba Perekes constituency. Thank you.
Morning, Chair. My name is Mackenzie Nkwazi Chipalamoto. I represent the people of Nkatabe North constituency, and I'm a member of this committee. Thank you.
Through you, Honorable Chairperson, good morning. My name is Chance Mundali, coming from Chitipa South.
Through you, Honorable Chairperson, my name is Sunge Kalumo, Parliament Secretariat.
Good morning, Chair and the whole committee. My name is Endless Nyari, Parliament Secretariat.
Good morning, Honorable Chair and committee. My name is Judith Malwa, Parliament Secretariat.
Thank you very much.
Good morning, Chair. I'm Peter Njinga, Parliamentary Secretariat.
Thank you very much. And my name is Anthony Masamba, Chairperson, Parliamentary Committee on Health. At this juncture, I would like to ask the stakeholder to introduce themselves, please.
Good morning, Chair. My name is Dan Namarika. I'm Secretary for Health. We are accompanied by Medical Council of Malawi, Pharmacy and Medicines Regulatory Authority, and Nurses Council with us. They will introduce themselves. Thank you.
Good morning, Chair and members. I'm Sherrod Mesoya, Board Chairperson for Pharmacy and Medicines Regulatory Authority, PMRA. Thank you.
Good morning, Honorable Chairperson. My name is Charles Menya. I'm the Director General for Pharmacy and Medicines Regulatory Authority. Thank you.
Good morning, Honorable Chairperson. My name is Davis Olowere. I am the Registrar and Chief Executive Officer for the Medical Council of Malawi.
Good morning, Chairperson and honorable members. My name is John Nebiara, Acting Registrar, Nurses and Midwives Council of Malawi.
Good morning, Chairperson and all the members. I'm Matikonda Mbendera, Director of Regulatory Enforcement, Medical Council of Malawi.
Honorable Chair and all members, good morning. I'm Emily Gama. I work with the Ministry of Health as the Deputy Director of Nursing and Midwifery Services.
Good morning, Chair, and all the members. My name is Simon Chawara Liwinga, Director of Finance and Administration at Medical Council of Malawi.
Good morning, Chair and honorable members. My name is Olivia Nkwadira, Communications and Planning Officer for the Medical Council of Malawi. Thank you.
Good morning, Chair and all honorable members. My name is Kesna Banda, the Registration Officer at Medical Council of Malawi. Thank you.
Good morning, Chair. I'm John Muhango. I'm the Acting Director of Professional Practice and Conduct, Nurses and Midwives Council of Malawi.
Good morning, Chair and all honorable members. I'm Joseph Josiah from PMRI. Thank you.
Good morning, Chair and honorable members. I am Eros Rodzeni. I'm the Vice Chair of Pharmacy, Medicines and Regulatory Authority. Thank you.
Good morning, Chair and honorable members. I am Chrissy Churu, Compliance and Enforcement Manager, PMRA. Thank you.
Is that all? Right, thank you very much. Once again, welcome to Parliament and Parliamentary Committee on Health in particular. Like I said, this is a continuation of the interface that we have been having as a committee with various stakeholders, including the Ministry of Health and others who have already appeared before this committee. We are conducting an inquiry, specifically looking at the corruption that is taking place in health facilities. We know that we have PMRA here. We already have a presentation, and we have seen the presentation. There are two things that we need to look at. SH yesterday spoke very clearly about these two things. So he spoke about the theft and the corruption. So theft is something different. Corruption is also something different. We are focusing particularly on corruptive practices taking place in health facilities. How are these practices compromising the delivery of quality health services to patients? How is it affecting the access or to health, to medical care services by patients? These are critical areas that we are looking at. So when you are making your presentation, please make sure that you are focusing particularly on these pressure points. Corrupt practices in health facilities. How is it hampering the access to quality healthcare services? I give you this opportunity now to make your presentation, but before I do so, I ask the SH if you could have a word or two before I hand over to the presenters this morning.
Oh, thank you very much, Honorable Chairperson and the House. We are pleased that we are with our regulatory bodies to present on the issue at hand. And by your guidance, we will try to stick to the two areas of main area of corruption and also talk into theft a little bit, because that's what is out there portrayed by the public. I'm not sure how much time each presentation is being given, Chair.
At least 10 minutes, max.
Thank you very much. So we'll start with Pharmacy Medicines Regulatory Authority, Chair.
I think you can proceed if you are ready.
Thank you very much, Chairperson and all honorable members here present, SH and colleagues from regulatory agencies. We have been allocated 10 minutes, so I'll sort of skip a few slides just to catch up with time. So I am presenting on behalf of the Pharmacy and Medicines Regulatory Authority. Like I've said, I'm the Director General. And next slide, please. So this slide basically just gives an outline of my presentation, and you will appreciate the same. Next slide, please. That's an overview of our mandate and establishment and the sort of the secretariat where we are based. And the next slide gives the mission and vision for the authority. I would request for the next slide, please. So, on this slide, I think this is where we're trying to give a picture in terms of our areas of focus in terms of regulation. As an authority, we have the mandate of inspecting pharmaceutical establishments, right from the manufacturing point, the distribution systems, to the point where medicines are being dispensed to the clients. At the same time, we also have the mandate of making sure that the clients or the patients are receiving medicines that are of safe and of quality standards according to the standards that the PMRA established. Next, please. So in terms of how our regulatory agency is linked to the subject matter, which is focusing on corruption, we are very much involved into operations that are targeting arrest of theft of medicines, especially from the public hospitals. And in terms of how we operate, we normally work in collaboration with the Malawi Police Service, the Drug Theft Investigation Unit, and ourselves as PMRA. At times, we also work with the MRA and the port officials, but frequently we work very much with the Police Service and the Drug Theft Investigation Unit. During our investigations, what has been noted is that we have two mechanisms through which medicines are diverted or are taken out of the hospitals. Smaller quantities disappear in form of pilferage, where members of staff would get smaller quantities out of the pharmacy or the wards where they are working. And the second mechanism is where medicines are diverted in large quantities, maybe at the point where medicines are being taken from central medical stores to the hospitals. And in between, that's where medicines also get diverted. Sometimes they are taken out of the hospital by way of theft through some sort of collusion with the fellow members of staff and maybe some security officers. So during joint operations, we focus on illegal possession of products because ideally medicines are supposed to be handled by those that are registered with us, and they are supposed to be kept in premises which we have also licensed. So in terms of how we conduct our operations, we target informal markets because this is where most of these illegal activities do happen. And the mode of operation usually is planned schedules and sometimes whistle blowing, because sometimes the general public would alert the PMRA of illegal activities through tip-offs anonymous. Now, when we have done our investigations and we find that there are illegal practices, the cases are subjected to two streams of approach. Either we take the criminal route where the police takes charge in terms of presenting the suspects to the courts, and where professionals are involved, we take the regulatory route where we subject them to a disciplinary process. And where we have identified other cadres who are not within the domain of PMRA, would always refer them to either nurses' council or medical council for appropriate disciplinary action. When undertaking disciplinary action against those that are suspected to have conducted an offense, traditionally we have three sort of punishments that are issued to the suspects if they are found guilty. So for any pharmacy malpractices regarding premises, we either enforce permanent closures, we either suspend the premises from operating a business, or we issue a warning. Similarly, when personnel are involved, we can either deregister, and what it means they cannot practice for a defined period, or permanently not practicing, depending on the severity of the case. We can also suspend the personnel or give them warning, depending on the nature of the case. So just to give a highlight in terms of the cases that we have handled recently between 2021 and to date, we had a case of pethidine where 5 pharmacy professionals working under CHAM in the northern region of Malawi were colluding with Central Medical Stores personnel to order excessive quantities of pethidine and then supply the same to the illegal supply chain. So when we made our investigations, we established that the drugs were not accounted for at the facilities where they were likely to be diverted. And then on the action that we did for those that were involved, because we are pharmacy professionals who were very conversant with how serious the transaction was involved, we deregistered them, and what it means, they are no longer practicing pharmacy in Malawi. We had a second case of theft or supply of expired insulin in 2022. So the PMRA was not notified by Mzuzu Central Hospital about non-responsiveness of insulin to patients that were receiving insulin at the time. And this insulin was supposedly purchased from Galaxy Pharmaceutical Wholesalers. Honorable Chairperson and members, insulin is a drug that is used in the management of diabetic conditions, and therefore you would appreciate how important and critical this product is. So upon our investigations, it was established that the insulin product was tampered with, particularly the label. And there was an alteration of the expiry date to indicate or to imply that the product was still viable for use, to cheat the users. And our further investigations also revealed that the insulin was sourced from Queen Elizabeth Central Hospital, where they had quarantined this product in readiness for disposal because it had expired. Honorable members and chairperson, you may wish to note that this product was received as a donation to Queen's, and at the time it was being received, it had a short shelf life. So the stolen insulin was supplied, I would say the insulin was stolen by a pharmacy technician working at Queen's at the time, and it was supplied to Galaxy Pharmaceuticals, where it was being relabeled and supplied to Mzuzu Central Hospital as well as other hospitals. So upon interrogation of the suspects, it was established that the procurement agent for this company, the Galaxy Pharmaceutical Limited, confirmed that they were buying the product from the vendor, in this case, the pharmacy technician based at Queen's. Honorable Chair and members, you may wish to appreciate that Galaxy Pharmaceuticals had 2 facilities, one in Lilongwe and the other one in Blantyre. The directors of the pharmaceuticals, the Galaxy Pharmaceuticals, as well as the pharmacists for both facilities, were indicated to us that procurement was done by officers from the institution who are not professionals, and obviously they were not too sure about the illegality of the activity that was happening. What action did we take as PMRA? So the pharmacists who were involved in this malpractice at Galaxy Pharmaceuticals were given written warnings, and the pharmacy technician from Queens who was supplying this expired insulin was deregistered and barred from practicing pharmacy in Malawi. For the premises in Lilongwe, the pharmaceutical wholesale premises were permanently closed and barred from doing business in Malawi. Apart from the pharmacists and other key personnel in the Galaxy Pharmaceutical Supply Institution, the rest of the key personnel in the institution were arrested, and you may wish to appreciate that the case is still in court because it was criminal in nature. We also had a case around 2012 where Nzimba District Hospital reported a pattern of death of babies from mothers who had been administered chloramphenicol as a prophylaxis in preparation for cesarean section. This activity happened between 1st and 30th November 2012. And members, you may wish to appreciate that the product in question was manufactured by Health Biotech Limited in India and was imported into Malawi by Galaxy Pharmaceuticals. As you will recall, Chairperson and members, that in my first slide or so, I talked about our role in inspecting pharmaceutical premises, including manufacturing company. This company, Biotech, failed good manufacturing practice inspections conducted by PMRA in 2012. What that meant was that the company was not registered in Malawi and was not eligible to supply medicines in Malawi. Members, through you, Chairperson, you may also wish to appreciate that in 2012, PMRA was operating as the Pharmacy, Medicines and Poisons Board, because we transitioned to PMRA in 2019 following the passing of the new act in the same year. So at the material time, PMPB did not have procedures for issuing import permit as we are doing now, where we scrutinize the eligibility of the medicines, the supplier, as well as the manufacturer in terms of compliance, the requirements according to PMRA guidelines. So further investigations revealed that Galaxy Pharmaceuticals, upon learning that there were issues at Nzimba District Hospital, they silently recalled all the remaining quantities of the product from the hospital and allegedly shipped them to the manufacturer without the knowledge and authorization from PMPB at the time. A few samples that were made available to PMRA for quality control testing, submitted alongside the complaint from Nzimba DHO, could not establish any possible linkage of the reported adverse events. And further testing could not be conducted because of the absence of quantities required for the same, because the remaining quantities had been taken out of the hospital. Chairperson and members, notwithstanding this, the authority initiated a disciplinary proceeding against Galaxy Pharmaceuticals on charges of importing and distributing unregistered products and conducting unauthorized product recall. The wholesale pharmacy license for Galaxy was revoked, and the proprietor for the Galaxy Pharmaceutical Company was also permanently banned from engaging in any pharmaceutical business in Malawi. Later on, the authority noticed that a son to the owner of the company that was banned, in this case Galaxy Pharmaceuticals, established and registered a new wholesale in the name of GPSL Pharmaceuticals. which was resembling the previous company, but was mostly using abbreviations, was not detailed. And this happened in 2019. Chairperson and members, you may wish to note that at the time this company was being registered, the board granted approval for registration of GPSL on the understanding that it constituted a separate establishment under different proprietorship. Linked to the cases of theft, Honorable Chairperson and members, currently we have cases that are listed on this slide. I'm not too sure if I have to read them through or you would appreciate in the interest of time. But maybe just to highlight the link between these malpractices to the guidance that you, Honorable Chair, provided, that how do these practices affect quality of services and access to medicines. Honorable Chair, you would appreciate that government provides resources in public hospitals for procurement medicines for the people of Malawi to access free of charge. And where we have theft and diversion, obviously the public is denied access in the process. And where these medicines are also diverted, we are not too sure of where they are kept. And in most cases, these medicines are also made available in an informal market and exposed to unfavorable conditions, which may also affect their quality. And then we can't guarantee their safety as well, where the public is accessing these medicines from an informal market, where the medicines have not been stored according to the required storage conditions. So, Honorable Chair and members, you appreciate that on this slide, we have a number of cases that are still pending in the court, where we have no control in terms of how quickly they can be processed. In our investigations, Honorable Chair and members, the paper-based inventory management system currently in use in public hospitals is a contributing factor to the theft and the diversion, because those in charge of the responsibility have challenges to account for, and in some cases where theft cases have been identified, there is some sort of manipulation of records, and then we fail to establish and conclude cases because of the same. Now, I take you, Honorable Chair and members, to the challenges that PMRA is facing. Following the passing of the Act in 2019, we needed to have regulations in place to enable us to operationalize the provisions of the Act. We submitted our draft regulations to the Ministry of Justice for processing, and you may wish to appreciate that the regulations are still being processed. Where we do not have regulations, Honorable Chair, we do have challenges to enforce some of the provisions in the Act, because the nitty-gritties that are required for us as PMRA to operate are not yet provided for. The second challenge, Honorable Chair and members, is that currently PMRA is operating in Lilongwe, and we do not have regional offices in the regions of the country, north, south, and probably eastern region. Issues of human resource capacity remains a challenge, where we have limited inspectors. And obviously, financial challenges cannot go without mention. Honorable Chair, with the global developments currently in place, the pharmaceutical market is becoming thin day by day. And you would appreciate, Honorable Chair and members, that as PMRA, our survival is heavily dependent on revenue that we collect from licensing and registration of premises as well as products. And where the numbers are declining, obviously it has got an impact on how much we are generating. And you may also wish to appreciate that on registration, the decision to register a product or to retain a product on the register lies in the hands of the market authorization holder. In this case, is the manufacturer, depending on how they look at the market for Malawi. Now, PMRA has no control over which products they should bring in, should they see that there's no business in Malawi. And in effect, it also affects us in terms of revenue collection. The other challenge, Honorable Chair and members, is where we have delays in clearing court cases that have been presented before the courts. And obviously, Chair, we also have limited control on how quickly these cases can be processed through the courts. What strategies have we put in place as PMRA to address some of these issues that I have highlighted? On regulations, Honorable Chair and members, we are working very closely with the Ministry of Justice through the Ministry of Health, the Office of the SH, to make sure that the processing of regulations is fast-tracked so that we are also effective in terms of our operations on the ground. On issues of personnel, Honorable Chair and members, you might wish to appreciate that PMRA undertook a functional review, which has given provisions for establishment of the regional offices in order for us to take the services to the people. And as soon as we got this approval, processes of placing members of staff commenced with the guidance of the Department of Human Resources and Development and OPC as well. So with the functional review in place, we are sure that we shall be able to establish the regional offices, but also recruit additional members of staff, including inspectors.
You have 3 minutes.
Thank you, Honorable Chair. This is noted. On strengthening revenue collection, we have put in place strict adherence mechanism to the prescribed currency as guided by the recent Gazette notice on fees, where we collect our revenue in dollars as prescribed. Where it is prescribed that we collect in Malawi kwacha, we're enforcing the same, so that we are adequately financed and we have adequate resources for our operations. We are also proactive in terms of revenue collection from prospective clients locally, and we are vigorously visiting and following up for payments. In line with the guidance from the government, we are implementing expenditure control measures to make sure that we save on limited resources that we have through the austerity measures that government introduced. And to address issues of efficiency, we have digitalized our regulatory processes, and we are continuing with the same in all other aspects of the regulatory processes, but the inspection and registration, we are processing licenses digitally. Finally, Honorable Chair, to empower the public to report on any cases of suspected theft and diversion of medicines, come 1st July 2026, we are introducing a tip-off anonymous hotline where the public will have to alert us on any suspected cases of theft and diversion of medicines. Honorable Chair, I thank you for granting PMRA an opportunity to present before you. Thank you.
Thank you very much. We quickly go to Medical Council of Malawi. You are starting at, I think 10. You are starting at 10, you are finishing at 10 to 11. So you have 10 minutes. You are starting at 10. No, you are starting at 20 to 11. So you are finishing at 10 to 11. Thank you very much.
Thank you, Honorable Chairperson, and thank you, honorable members, for the opportunity for us to come as led by the Secretary for Health and Sanitation. The first slide presents the outline of what we prepared to present, which was shared with Parliament 2 days ago. We'll focus on the key areas only in the interest of time. Honorable members, you know our mandate. We were here again some 3 months ago, so I will not go through the mandate. Suffice to say that the Medical Practitioners and Dentists Act of Malawi of 1987 gives the Medical Council the responsibility to regulate medical, dental, and allied health practitioners. Through that act, we have 5 responsibilities of regulating practitioners, health facilities, training, disciplinary, and playing an advisory role. Coming straight to the conversation of the day, these are the common corrupt practices that are being handled at the Medical Council of Malawi. The first one is charging for services meant to be for free at the point of care. We have received a couple of really concerning reports. I'll give an example of a patient who came to the Medical Council complaining that they were made to pay for services and they had to go back home to sell their only piece of land that they depended on, which is pretty sad. So the essence of charging for services meant to be for free is pretty common. And there is also abuse of part-time private practice, where the employer has allowed them to go and work for locum elsewhere. Some practitioners tend to abuse that timing. The third element that we have been dealing with is on stealing of medicines and supplies. Most of these cases are referred to us by the PMRA, as the Director General reported, that if it is a practitioner who is regulated by the Medical Council, they will report them to the Medical Council, and we do take on those cases and deal with them from a professional point of view. The fourth element is using public resources for personal benefit. What we have seen is that some practitioners would refer patients for care outside the facility if it is a public facility, when those services are readily available at a public facility, so that where they go, they have to make some money from the patients. But we have also seen that an example of that would be usage of diagnostic and treatment services for benefit at a personal level. The scary one, honorable members, is issuing of fake medical or internship reports. That's another form of corruption that we have seen. And related to this, of late, we have received cases where practitioners come and apply to the Medical Council of Malawi when their certificates are fake. But we are able to identify them, and as I'm speaking, we have a number of cases in court where we got them arrested, and we do our due diligence to make those investigations and trace them. These acts of misconducts, according to the Act, are categorized as disgraceful or unprofessional conduct. Now, we have a couple of observations from the Medical Council pertaining to these acts of corruption. The first one is that really these acts of corruption are practiced by a few number of practitioners, about 1%. At the Medical Council, we have about 14,000 registered practitioners, but those that practice these, like for 2025, were about 101. So it's a few practitioners, but the level of what happens is what is pretty scary. So as much as we have to think about those that are doing it, we would want to commend those practitioners that are not doing it, which is pretty encouraging. Now, when we review the information, we have the data on why these corrupt practices are prevalent. Honorable members, our conversation so far when we do a root cause analysis has been thinking about moral decay and lack of integrity. We have seen that there's prevalent unprofessionalism amongst some practitioners. Secondly, it's an element of inadequate human resource, but also inefficient human resource monitoring system, where some practitioners employed by their employer leave the facility, go and do personal issues, and if there is no good way of monitoring, we'll never know if the practitioner is there. We were very happy to hear that Mzuzu Central Hospital have installed CCTVs and are really able to monitor some of their workers. We saw in the papers. I think that's one of the really good things about, monitoring of health systems that would be helpful. For example, in terms of human resource, when we look at the number of practitioners we have in Malawi, about 3,000 practitioners registered, active, practicing in Malawi, and compared to the population of 22 million we have in Malawi, members, you will see that the ratio is about 1 medical doctor to about 8,000 Malawians. That is very high. The global average at the moment is 1 to 600 population. So we are having a really big human resource gap in Malawi, and when we go to those facilities, there is also a high vacancy rate. We have also seen that there is increasing demand for health care in the context of inadequate resources and the ever-increasing population. Honorable members, you might agree that we are doing very well to build new health facilities. But data in Malawi shows that every 50 seconds, there's a new birth in Malawi. A newborn. I mean, yesterday we were reading for Kasungu, we are told that about 80 births per day, Kasungu alone. So the ever-increasing population balancing with the current human resource and the resources that are available for health care could be what is causing the burden and then resulting for some practitioners in these corrupt practices. But there is also, honorable members, issues of poor remuneration and increasing cost of living. And we have had scenarios where patients have also enticed some practitioners, but this is usually as a result of inefficient systems and inadequate resources, which have pushed patients wanting to get the services quicker than they are allocated at the particular time. Now, in terms of how these issues of alleged corruption, how they are being handled at the Medical Council, we receive a lot of complaints from the public about this, and our source of complaints are the patients and their representatives, as we can see from the slide. That's stage number 1. We also receive some of these complaints from institutions like the Anti-Corruption Bureau, Ombudsman, employers themselves, like the hospitals, even the Ministry of Health is also referring these cases for processing at the Medical Council. Some of these cases, we pick them up in the media. As long as there is adequate information for us to be able to follow it, we will take that issue and follow through. Then an investigation is conducted on those issues. Once the investigation is conducted, that's stage 2, the reports are vetted, and stage number 5, there is a disciplinary hearing committee that is conducted where the complainant, the practitioners are called together to present each side of the story, and then determinations are made. During the disciplinary hearing, the Ministry of Health, Ministry of Justice, Department of Statutory Cooperation are always part and parcel of that team, and the public is represented. And then once a final decision is made, feedback is given both to the complainant, the public, but we are also every quarter publishing these findings through the social media, through the newspapers, as well as through the website and of the Medical Council of Malawi. All this is in order to educate the public to know they have got a way of complaining if they face them. And this has resulted in an increasing in the reports that we have been handling. Honorable members, as you can see on this slide, moving on from 2018 when the Medical Council received only 19 reports and we were able to process only 10 of those complaints, going to 2025, we received 101 reports. Out of those 101, we were able to process 75 reports. Our hope is that we should be able to resolve all of them, but you can see there is a gap, almost 26 that we are not able to do. Issues of human resources, gaps, issues of resources not being adequate have been some of the things that we have been facing. Coming on to the concluded disciplinary cases, honorable members, we can see that the corruption is happening in all types of facilities. The first pie chart we can see, we would appreciate that 32% of these cases are happening in public facilities, 29% are happening in CHAM facilities, as well as Islamic Health Association of Malawi facilities, and whilst 26% are happening in private hospitals and 13% are happening in private clinics. Moving on in terms of the profession, we will see that the medical doctors are responsible for the 34% of those types of cases, clinical officers about 38%, then we also have got diagnostic staff. Because these acts of corruption also involve laboratory services, radiography services, that's why you see that about 10% are happening in those type of staff. And lastly, in terms of specialty, I want to take you to the blue. There are two blues there. You will see that ethics and professionalism, which are specific to these types of cases, are the topmost, 25%.
So out of the 101 we handled, 25 cases were cases related to the corruption and the unprofessionalism that we talked about. In terms of where the practitioner has been found guilty, what happens? Honorable members, you will see that we had to pull out a couple of offenses related to this, where they have illegally charged patients for services meant to be for free, or where the practitioner has received kickbacks from patients. The minimum penalty is suspension for a maximum of 4 years, but they are also required to pay for the cost of the investigation. The maximum penalty is deregistration. Deregistration, when practitioners are deregistered, they have a chance of being placed back on the register. But once we erase, is also one of the penalty. They can never ever practice in Malawi or anywhere in the world. Because if they go anywhere they go, they will ask them if they are registered by the medical council. And the medical council will be able to give evidence that they were deregistered. When they are convicted criminally, let's say the PMRA took that practitioner to court and they have been convicted, they can also be suspended from the register or be deregistered by the medical council as long as they are a medical, dental, or allied health practitioner. Now, when they have issued fake medical reports or even fake internship reports or submitted fake registration certificates to the medical council, they are suspended for a minimum of 1 year, but the maximum penalty there is erasure. So that is how these cases have been handled at the Medical Council of Malawi. Honorable Chair, allow me the last minute. Because of time, I will stop here because I've handled a lot of the issues that are in the preceding slides. Suffice to say that we have done a lot of work to prevent these things. Now at the Medical Council, we demand that every institution include issues of professionalism in their curriculum. Secondly, we have been doing awareness. We visit every hospital annually. We also do visit the health training institutions to talk to students. And lastly, we also visit their associations. Another element that we have been doing is that we have gone digital. Now a registered practitioner at the Medical Council, I mean, we just went digital on Monday, honorable members. You can easily search whether someone is registered by the Medical Council. But also our practitioners can easily apply through the online system. And that will help people who go to access health care to verify if their practitioner is really a registered practitioner. But we also do produce a list of registered practitioners for the whole public to be aware. In terms of the last request we have from this honorable house, honorable members, we have a health professions bill that is at the level of the Ministry of Justice. In there, we have included more stiff penalties. We have included issues related to dress code and identification of practitioners. So we would be hoping that once it comes to this honorable house, you'll be the ones who are going to support that bill so that it can be passed. So we have tried to make more stringent penalties through there, but also where resources are available, we always appreciate the support that this honorable house has been giving to the Medical Council of Malawi. Honorable Chairperson, that's the last slide from the Medical Council.
Thank you very much, Medical Council. You have done 13 minutes. We go to Nurses Council, 10 minutes.
Good morning, Chairperson, honorable members. This is Nurses and Midwives Council of Malawi to make a presentation on the issue at hand. But at the outset, let me say that as Nurses and Midwives Council, we are excited to be part of this conversation because nurses and midwives is the face of any health facility. So when issues of theft, corruption, and the like are happening, it really disturbs us as a regulatory body of the profession. So, Chairperson, that's what we have prepared to share. Of course, we are already familiar with the mandate of the Nurses and Midwives Council of Malawi. We are going to also have a quick look at the regulatory functions, the mechanism for resolution of cases that Nurses and Midwives Council receive, the nature of the cases, especially we just extracted from the April 2024 to May 2026, the type of cases that we have received. Then just to share with this committee the types of the allegations, and indeed we'll proceed to see the interventions to address the misconducts, negligence, and professional misconducts that we see with our practitioners. Last but not least are the challenges that we face as we transact our regulatory mandate. Chair and honorable members, that's what explains the legal basis for the existence of Nurses and Midwives Council. We are guided by the Act number 16 of 1995, and we are there to regulate the nursing, midwifery, education, training, practice, and conduct of those registered under it. So as Nurses Council in training institutions, we are talking about developing the syllabus that will guide curriculum implementation so that in the end, we have a product that is able to deliver what the Malawi society deserves. Not only in the training institutions, we also look at the issues of nursing in the hospitals, in the health facilities, to see how the nurses are practicing. And we also actually very mindful of conduct. Provision of service is another aspect, but also conduct is something that we expect from our professionals. Chair and honorable members, the regulatory functions, we are talking about development and review of syllabi and regulatory tools, the registration and licensing of health facilities, as well as nursing and midwifery workforce. Ours is a profession. For them to practice, they have to be licensed. So that's what we basically do. Investigation of cases is very important for this meeting because that's where we are revolving around. And also monitoring and evaluation. As Nurses and Midwives Council, we are required to go around in the various health facilities in the country to see how the nursing and midwifery services are being provided. Chairperson and members and honorable members, this is just a synopsis of the mechanism that is there in the Nurses and Midwives Council setup in terms of how we address issues or complaints that have been lodged with us. First thing is investigations. When we receive the cases, the complaints, there is a team that goes around to investigate. And the reports are submitted or presented to the investigation committee of the council. After that one, the investigation committee escalates issues that have come out of that committee to the disciplinary committee of the council. At this point, penalties and everything of that sort are meted. And indeed, we also make referrals because the nature of our job, we work with our other players in the health facility. So if the case is to do with medical council, we make referral to medical council. If the case is to do with PMRA, we also do the same. We also make referral to security agents like the police if the case is of that nature. For instance, maybe if it's a rape case. This is just to depict the cases that we've been able to handle in the period January 2024 up to May 2026. Chair and members, we have nature of cases, districts where those cases took place. We kind of try to identify the health facilities, but just to get that it happened in which district in Malawi, and the status where we are in terms of resolving that case. So some concluded, some under investigations, as it is depicted in this presentation. Chair, let me also just mention that the nature of the complaints that we do receive as Nurses Council is threefold. It's about malpractice. This is doing something contrary to what you know as a nurse or a midwife. Secondly, is negligence. You know I'm supposed to do this to a patient, but you do otherwise. That's negligence. And then professional misconduct. If you report, for example, for duty while on drug, that's professional misconduct. So these cases that we are sharing here are all to do with those main areas in terms of the nature of the cases. Chair, the recorded cases in 2024 to 2025, we had 16. In 2025 to 2026, we had 14. This year is still ongoing, and we have so far registered 3 cases. We felt as Nurses and Midwives Council, we should share sources of complaints. Most of the cases that we do receive are coming from maternity. And when we talk about maternity, it's all antenatal care, labor and delivery, postnatal care, and neonate. We also receive cases from the general wards, as well as cases that have happened outside the hospital arena. Types of penalties is the next that we want to share. Chair, when the cases have been lodged with the council, the outcome could be a warning, dependent on the severity of that case, or just admonishing that particular practitioner, or caution. In that case, we are writing something to the practitioner or to the health facility involved. Suspension is also one of the remedies. Deregistration, and that is associated with the period of time that the disciplinary committee determines that a particular practitioner has to be removed for a specific period. Cancellation is also one of the penalties. Erasure, completely taken out of our register, is also one of the penalties. And last but not least, we make referral dependent on the nature of the case. Chair and members, the things that we are doing, interventions. So we started the review of the Nurses and Midwives Act. You can see this one is an Act number 16 of 1995, so many years ago. And we revised it, we finished last year, but it's at the stage of at Ministry of Justice, waiting to be tabled in this August House. And I think that's where we also need your support, Chair and honorable members, to have this, because it has included issues that are bothering us currently. Revision of the Code of Ethics and Conduct. As nurses and midwives, we are guided by a code of conduct. We have reviewed that one to include issues that are current. Development and review of nursing and midwifery care standards. That is also to make sure that we are up to date in terms of what is expected of us as service provider. Development or review of midwifery competences. We are moving towards a situation where our nurses' performance is measured on competency, not just mere acquisition of knowledge, but we want them to be competent and demonstrate that when they are providing patient care. We are disseminating all these documents because there are so many players that are involved in the provision of nursing and midwifery care. Chair, we also have radio programs so that society is aware that we are there. If issues of nursing and midwifery happen, they should report to us. Introduction of the toll-free line, we have that number to improve accessibility. of nursing and midwifery regulatory services. Chair and honorable members, there's what we call continuing professional development. We understand our profession is dynamic. Things keep on changing. To make sure that nurses and midwives keep abreast of current events, there's this intervention. And we also have a satellite office now.
You have 2 minutes.
To increase our visibility. Challenges, Chair, I talked about the bill that is there at the Ministry of Justice, and would love to have it supported and passed into an act so that we address so many issues that we mentioned. Delays by facility ombudsman office to report cases. We work with facility ombudsman offices, so we have some delays to receive cases from them. Missing of patient records is also one of the challenges. When we are going to investigate, we don't find some records. Public awareness of the existence of the council isn't that 100%, and that's why we have those radio programs. Disenfranchised society is one thing, Chair. Not so many are able to report cases even if they haven't received proper care in the facilities. Professional remedy and versus compensation. Some think Nurses Council is there to give compensation. So the expectation is like it dwindles when the address is to do with professional issues. Resource constraints is one of the issues that also affect us to quickly investigate the cases that are reported to us. Chair, that's what we had as Nurses and Midwives Council to share. Thank you, Chair, and honorable members. Thank you.
Thank you very much for that beautiful presentations, very insightful presentation. So, we've been having this interface with various stakeholders starting from Monday, but we deliberately wanted to have you here today on the final day because you are regulators. Most of the cases being reported here are involving your staff members. That's why this committee decided that you appear on the final day after hearing from other stakeholders. Time for plenary. Honorable members, questions, Nzomba City South. Then we go to Kotakotankula. From Kotakotankula we go to the people, the wise people of Chau Central East. From Chau Central East we go to the people of Chitipa South. Then we finish off with the people of Nzimba Perekezi. Thank you very much. In that order.
Chairperson, thank you so much. And through you, I should thank SH and his team for the very elaborate presentations. Chair, I have 2 questions. But first, let me mention that I think we are living in a time whereby the moral decay, as presented by Dr. Zolowere, I think is a concern. I think no sector has been spared, and it's sad that even the medical practitioners, they also accept that the moral decay has also gone into the professions. It's very sad. As a medical doctor, a nurse, working while being supervised under a CCTV, I think it's very unfortunate. It's supposed to be a calling. It used to be a calling, this profession. Anyamata Kuba, you know. So it's a very, very unfortunate. But I think I should commend SH and your team for the fantastic job that you are doing. Chair, I wanted the Medical Council and the PMRA also to clarify certain areas. The issue of Galaxy Company. Me, I was smelling some criminality in that. So I was very disappointed that the company, was it closed? But the owner was not even apprehended. But I was smelling some criminality. I think those actions of selling us, was it insulin that was expired? I think this is criminal. So I thought maybe SH would also want to speak to that. Does it mean that our acts, whether it's a PMRA Act or Pharmacy Act or indeed the Public Health Act, are inadequate to catch these criminals and make sure that they don't repeat? Because if you let them scot free, they can do it again. And this is what the presenter also mentioned. Because I think the penalty was not adequate. So I thought maybe SH would want to speak to that. Secondly, Chair, PRMA did mention about a short shelf life of donations. And I think one of the products, I think it was insulin, it had a short shelf life. I think the Director General mentioned that. But I don't know if you have taken an action to say, do we continue to receive donations which have got short shelf life? I didn't hear any action on that one. Finally, Chair, I said 2 questions, but allow me to ask a third one. Medical Council, it was a brilliant presentation, but we said we have got issues resolving cases. For 2025, we are remaining with 26 cases, if I got you correctly. I wanted you to maybe to zero in what type of cases are remaining. Are these very serious ones? And in the meantime, because you have not resolved them, what is happening? Are you using the same transfer issue, asking the DHO to transfer someone because you have not resolved? Because the transfer, let's face it, it's not a solution. You're only moving a problem from Muncheu to Baraka, etc., etc. So I also wanted to hear from the Medical Council, what is happening in the meantime with these 26 unresolved cases? Thank you, Chair.
Thank you very much, the people of Zomba City South. I think I need to make some guidance here. I know SH may want to tackle your first question regarding the Galaxy, but these issues are in court. When we are coming up with this inquiry, we are mindful of the fact that we have this issue which is under investigation and it is in court. Well, the SH might choose to address these issues carefully, considering that the case, and that's what the clerk is telling me here. I think SH, for the avoidance of other legal issues, we may paint this question and consider the other 3 questions or 2 questions that the people of Zomba City South have asked. We go to Nkota Nkula.
Thank you so much, Chair, for granting the people of Nkota Nkula to ask 2 quick questions, 2 brief quick questions.
Directed to who?
To
PMRA.
PMRA.
Okay.
I like the MRI thing, but the addition of P. Yeah, to PMRA. You mentioned of delays in finalizing the regulations at the Ministry of Justice. The question is, do you have any specific legal reforms that you would like Parliament to prioritize so that they empower you to act decisively? I think that's clear. The second one is, would you like Parliament to legislate mandatory disclosure of disciplinary actions across all regulators or hospitals, just to make the patients and communities aware of breaches and sanctions? Is it making sense? Thank you so much. So those are 2 brief and very quick questions.
Thank you, the people of Nkota Nkula. The first one is about the regulations. We know the regulations are there and other processes are happening. But in the meantime, what else can Parliament do regarding the legislative reforms that PMRA would want this committee to advance in the National Assembly, considering that the other processes are already taking place with regard to the regulations. And the second one is also coming from the people of Nkhotakota, where he's asking or seeking clarification whether the regulations may also want the mandatory disclosure of disciplinary actions taking place. Right, we go to Nzimba Perekezi.
Thank you, Chair, for giving the people of Mzimba Perekezi to ask some questions. But also, let me also thank the SH and all the presenters for their wonderful presentations. Chair, I've got two questions. The first one goes to NMCM and the second one to PMRA. To NMCM, CSOs emphasize the importance of community oversight. How can NMCM advocate, integrate civil society and the patient advocacy groups into the regulatory framework so that we should ensure equity, protect vulnerable patients and from misconduct? The second one goes to PMRA. What real-time pharmaceutical tracking systems or mechanisms currently exist to prevent stolen drugs from re-entering the public supply chain under the altered labels? Thank you.
Oh, thank you very much, the people of Nzimba Perekezi. Just to reinforce the point regarding the issue of the first question coming from the people of Zomba City South. So, Standing Order 192, 1, a matter before court of law, subject to the right of the Assembly to legislate on any matter, matters awaiting or under adjudication in any court of record shall not be referred to any motion, debate, or question from the time the case has been set down for trial or otherwise before the court if there is a real danger of prejudice to the trial of the case. That's why, SH, you cannot tackle that question because we are aware that issue is in court. Thank you very much. We go to the people of Chitipa South.
Thank you so much, Honorable Chairperson, for yielding the floor to the people of Chitipa South. The people of Chitipa South intend to ask two questions to PMRA. The questions are a direct reaction to the presentation by the Director General. In his presentation, the DG mentioned that they intend to go regional following the functional review. And it is the understanding of the people of Chitipa South that if regulators are visible, some of these corrupt issues can be minimized. So the people of Chitipa South want to establish from the Director General when exactly PMRA will go regional. The second question emanates from the Anti-Corruption Bureau. Yesterday, we heard from the Anti-Corruption Bureau that 35% of the medicines, public medicines, are stolen. And the figure is quite alarming. It is the wish of this committee, first of all, to confirm with you as a regulator that is it true that 35% of our medicines are stolen? Moving forward, we would also want to hear from you as a regulator. What measures do you intend to put in place? Because most of the people that we hear studying medicines are people who you regulate. These are pharmacy professionals. If it's true that 35% of our medicines go in the drain, what are you doing as a regulator to curb the same? Thank you so much, Chair.
Thank you very much for those questions coming from the people of Chitipa South. Just to also comment on the final question. So the 35% drug theft is taking place between, at the point where the drugs are taken out of the central medical stores, going to going to various destinations, and the drugs are diverted to private pharmacies along the way. So I think this question can also be addressed by the SH, because these are the public drugs coming out of our central medical stores, getting diverted to private pharmacies and institutions as they are going to their designated destinations. So SH, take note, and of course, Primary, you can also come on. The people of Wancheu Central East.
Thank you, Chair, for recognizing the people of Wancheu Central East. My first question is to the Nurses Council, especially on the point of training. I'm not clear the way the Nurses Council is administering their qualifications. For example, first of all, there's this cadre of nurses, understand the midwives, there's 1 year training. These people, I wonder if they are indeed regulated by Nurses and Midwives Council of Malawi. I'm asking these questions because these nurses, they're not even allowed to work in private hospitals. They're only allowed to work only in government peripheral areas, remote health centers. Secondly, on the training of nurses, 3 years. What I know, at first, nurses were trained, they were getting certificates in nursing after completion of nursing and doing midwifery. They were given those certificates that they have completed training as a nurse midwife. Currently, because maybe of political interventions, these people that are now offered diplomas. So it's confusing in terms of employers that why should somebody be given a salary of a diploma, yet they're supposed to be given certificates. And if they are going for upgrading, I understand probably these are ordinary midwives for a degree program. They need to undergo for almost 3 to 4 years. Yet somebody who is a state registered nurse, after obtaining a diploma at Campus College of Nursing, he can go only for 2 years to obtain a degree. So I'm wondering if their diplomas, are they equivalent or not? Please clear us on this point. Thank you.
Thank you very much.
The second question is to the PMRA. Yesterday we had the Anti-Corruption Bureau here, and the Anti-Corruption Bureau was claiming that about 35% of drugs are diverted from central medical stores on the way to the district hospitals. Even if you try to find out, you find out that most of the drugs, about even out of that 35%, about 20%, they cross the borders outside this country. For example, if you go to Dar es Salaam, there's a city called Kariako, you'll find drugs being sold by vendors in markets, labeled property of my government. So I'm wondering if PMRA is serious on this, especially with your security agents. For example, if people that are traveling from, they have embezzled the drugs from Lilongwe Blanta to the border Karonga, there are so many roadblocks on their way. So what are I doing as the PMRA to see to it that our drugs should not even cross the borders? Thank you.
Thank you very much. The people of Wancheu Central East, the wise people of Wancheu Central East. for those beautiful questions, comments, and observations. The continuous development programs of nurses and midwifery. Please take note. We go to Nkatabe, we go to Nzimbasolora, the final one.
Thank you, Chair. Before I ask my questions, I would like to give a point of order. Is it an order that Zomba City South to say Anyamata akubwera panoa ndakuba? I don't think it's a good way. Thank you.
Thank you for that point of order. And we rule Zomba City South out of order. Thank you very much.
Thank you. I should continue with my questions. My questions goes to Minister of Health. If low salaries and staff shortages drives corruption, what is the ministry doing to fix these root causes? And secondly, if private practice abuse persists despite regulations, who is failing in enforcement and oversight? Thank you, Chair.
Thank you very much. Two questions from the people of Zimbasolora going to the Ministry of Health, low remunerations and other conditions associated with health care.
Patients are educated on the medical standards. The second one is on same to MCM, part-time private practice. Has been lots of people have mentioned about it, and as being one of the factors or one of the issues that's causing absence of doctors from the hospitals. That's the services are suffering because of the private practice. Why has MCM not banned or strictly regulated it? Are we protecting doctors over the patients' lives? In addition to that, or should we consider banning or strictly regulating it? What legal reforms, what specific legal reforms would you want Parliament to pass so that they can give you powers to stop the abuse in the hospitals? The last one is on the community oversight. That has been pushed by PAWEM. The PAWEM and CSOs were in the forefront pushing for this oversight. Why hasn't MCM integrated the civil society into your regulatory framework so that you do an inclusive, consolidated scrutiny? Thank you.
Thank you very much. The people of Dowamput, as a matter of fact, SB was here yesterday. They asked this committee that wish to advance legislative process in the National Assembly to the effect that there should be a ban of private practice by the medical doctors. Because according to SEB, the corrupt practices in health facilities are also being influenced by the private practice by the medical doctors. MCM, kindly take note. Pemare, it's your time to start tackling the questions. Then we move to MCM, then Nurses Council.
Thank you very much, Honorable Chair and honorable members who have asked questions to PMRA. With your guidance, Chair, I will only go straight to one question from the honorable member from Zomba City South, where the honorable member is asking about whether, I think in relation to the short shelf life of the donated insulin. Chair, and members, you may wish to know that PMRA has donation guidelines that should be followed whenever a donation is to come into Malawi. And for a donation to come into Malawi, we request for documents that provides all the required information regarding the provisions established by PMRA, one of which is labeling, where on the label you would find information about shelf life, when is the product expiring. When we scrutinize that, we grant approval. When we are not in agreement, we do not accept. And the Ministry of Health also has got guidelines that also stipulate that any donation coming into Malawi should have at minimum 18 months shelf life. Now, we are also guided by the same to say, if anything, okay, maybe before I talk about that, the whole reason why this period is prescribed is basically to allow for the transit time, the distribution in country, and then the use of the same when we have the product on the ground. So we have guidelines in summary, Honorable Chair, and then we issue import permit for donations. And this is one of the things that I'm also doing. I'm happy to report that even the ministry, when they are receiving donations, they will apply to PMRI to say, we are receiving donation X, would you grant us permission to, and we have documents to that effect. Of course, maybe we may not have brought them here, but we do. So the challenge with donations of this nature, Honorable Chair, is that sometimes people are not in the know. We have facilities like Queens, for example, you've got specialists and experts who have connections with some other colleagues maybe outside the country, and then they would donate direct to them. And this is probably where we have this, because they're not in the know about the existence of the guidelines. Maybe going forward, Chair, it will be an issue of increasing sensitization about the existence of the guidelines, but also the protocols that have to be followed. The second question came from the honorable member from Nkhotakota, Nkula. Is it Nkula? Nkula. Sorry for pronouncing it wrongly. So it was linked to our challenge on delays in finalizing regulations. And the question was whether PMRA would need any legal reforms that Parliament or this honorable committee would probably help to intervene. That's one thing. And then the second question probably is also linked to the same, because it's linked to legal reforms in a way. So let me handle it simultaneously. The answer is yes. And where exactly? I will take you to the point where the Act provides most of the fines that have been outlined in the Act. They are talking about the court administering the fines. Now, when you have inspectors on the ground doing their work on a day-to-day basis, they come across an issue that requires an immediate or an administrative fine. We're sort of not allowed because of how the Act was crafted to say, upon conviction and sentencing by, you see. So in that effect, we are sort of limited to enforce, unless there is a separation between those fines to be administered by a court after taking through the court process, and then we have separate administrative fines that the inspectors can impose there and then. So this is probably where we need the intervention of this honorable committee. And you asked about should Parliament, okay, so it's linked to the same mandatory disclosure or something. I didn't get that one right. If you may come again on that one.
Can you use mic?
Yeah, okay. So what I was trying to say is, would you like Parliament to give you power to disclose the plenary actions that are taking place? Yes. Is it clear now? Thank you.
Yes, honorable member for Nkhotakota Nkula. Yeah, thank you very much for this clarity. If that is doable, Honorable, this is going to be appreciated because we do have some gaps in the Act where sometimes if a decision is made to publish the disciplinary actions that the regulator has done, there's always fear to say, are we not going to be sued? Because we are an entity that can be sued by nature of its existence. So if we have clear provisions in the Act to say where the authority has taken its regulatory disciplinary measures, the authority is cleared to proceed and publish, we can also be happy to have that kind of intervention through this committee. Thank you very much. Question number 3 came from Nzimba Perekezi. I think this was related to the presence of a real-time tracking system in relation to, was a preventive measure to prevent re-entry of drugs into the public circulation, right? I think this would probably be tackled by SH, but maybe I can preempt to say the ministry is working towards digitalizing the supply chain to have a system that gives real time and visibility in terms of movement of commodities from the central medical stores down to the last mile, and then how the same should be accounted for using the national identification system. I think SH will highlight that one as he's concluding his remarks. Question number 4 came from Chitipa South. This was in relation to the establishment of regional offices, as mentioned in the presentation by PMRA. The question was, when are we having these offices in the regions? Let me indicate to Honorable Chair that as PMRA, as soon as we got approval of the establishment, after the functional review, we are set to start implementation. The first step that we had to undertake with the support from the government was to do placement of staff members. Because as you are aware, Honorable Chair and members, PMRA formerly existed as Pharmacy, Medicine and Poisons Board. So we had staff members who were recruited under that establishment. And then when we transitioned to PMRA as an authority, we undertook the functional review so that we have got proper bodies in position to execute the new mandate. So placement has been done. Of course, we have got a few challenges to that effect. But one of the provision that is in the new establishment is the creation of the office. So what has prevented us so far is probably you are aware that there is a recruitment freeze currently being enforced by the government. So as soon as this is lifted, we'll commence recruitment processes and then we'll have the offices established. The other question, was it also from Chitipa South? It's linked to the ACB 35% drugs stolen from public health facilities. Maybe not necessarily to agree with the percentage because we have not seen the report and what sort of assessment tools or methodology was used to establish these figures. But wholesomely, we can agree that pilferage of medicines is really an issue that is haunting us. And the limitations that we have to some extent is how the same is handled through the court processes because it takes time to clear them. And obviously, our hands are tied, like the Honorable Chair has also alluded to. There was also an issue to say the majority of these medicines are lost in between central medical stores and the health facility. And the question was what action is being taken. I just wanted to mention through you, Chair, that vehicles that are transporting medicines from central medical stores to the health facilities are tracked. There is a tracking system that is in place. And any illegal diversion using a central medical stores vehicle would be captured through the system. But the diversion that is being mentioned here is where hospitals have run short of medicines in the middle of the routine supply cycle of the central medical stores, where now they use their vehicles to go and collect medicines from the central medical stores. And then their vehicles, they are not tracked. And this is where the opportunity to divert comes in, but not the central medical stores vehicles, because they are tracked. The other question, I think this was also linked to the cross-border issue, medicines labeled for Malawi government found in Kariakoo, in Tanzania, across here. We may need to establish, but we'll task our inspectors, and probably maybe with the guidance of SH, maybe we may have to go and see to some extent across the other side to say, how do they get these medicines from Malawi across the borders? And we are also going to see how we can collaborate with our counterparts from the Malawi Revenue Authority and all those that are managing the border posts. So through the Office of the SH, we'll ask for a coordination and a collaborative mechanism to see how best these medicines, of course I know maybe they use uncharted routes. I don't think they go through the normal border posts, but this is something that we may have to establish. And the other question, I think, is for the ministry. I think for PMR, these were the questions that I took note. Thank you.
Thank you very much. We go to Medical Council of Malawi.
Thank you, Honorable Chair and Honorable Members, for the questions that were shared. From the Medical Council of Malawi, the first question we received was on the 26 remaining cases from 2025. Honorable Member, all cases that are reported to the Medical Council are always concluded. It's just that by January, when we were finishing the financial year on the 31st of March 2026, we had 26 cases that were remaining from the previous year. But as I'm speaking, I can confirm they are all serious cases, and all of them are at different stages of being processed. About 10 of them have already been investigated. We already took them through the disciplinary committee, and on 25th and 26th of June, they are going to be presented to the board, which is the main council for decision making. The other remaining about 16, they are being planned for presentation to the disciplinary committee the first week of September, together with some cases that have been reported newly in this financial year. So we can assure you that every case is taken until conclusion, but what we wish for is that within 6 months, we hope to be concluding all those cases. That's what we are intending to do. We'll be able to do that with more resources, including human resource. Honorable members, the second question was on mandatory disclosure of disciplinary case outcomes. We are happy to report that the Medical Practitioners and Dentists Act, Section 53, already mandates the Medical Council to publicize the findings of all disciplinary cases. And this is the reason why at the Medical Council, after the board has concluded the case, would always put up a press release in the newspapers, and then would also make them widely known, because we have seen it has improved even reporting of similar cases, but also made other practitioners to learn and avoid doing similar issues. The other question that came to the Medical Council of Malawi was on including the public in regulation. We are happy to report that already the Act provides that the Medical Council of Malawi Council itself should have representative of the public, and as the government is appointing members, that is taken into consideration. But also, when we are handling the cases at the disciplinary committee, patients and the public are always represented. We can give an example of the Malawi Health Equity Network, which is an organization that represents patients. They are always available in the disciplinary cases, because we want the voices of the public and the voices of the patients to be taken into consideration. So that one is already handled. The last question, Honorable Chair, was on Anti-Corruption Bureau and private practice. And I think that's a big elephant in the room that has been conversated at all levels, and it's really critical for this committee to be aware. Honorable Chairperson, at the Medical Council, we have different types of private practice. We have full-time private practice, where a practitioner doesn't work for example, for the government, but they own the health facilities themselves, and that is what they do full-time. Very much less issues there. Of course, we know that other unscrupulous practitioners can go steal drugs from another facility and sell there, but every time we visit the full-time private practice, we are always checking the evidence of where they bought the drugs. And PMRA do the same. We also do the same as Medical Council. If we find that there is a drug without a receipt, and that receipt has to be from a pharmacy that is regulated by the PMRA, if we find that drug, we close that facility and we hold the facility accountable for theft. And the practitioner themselves are held accountable by the Medical Council, and the license is sometimes actually withdrawn whenever we find those cases. So I want to assure this committee that there's a lot of work that is being done about that already. The second type of private practice, honorable members, is part-time private practice. And part-time private practice is where that practitioner is employed by another employer, but during their free time, they go to work elsewhere. And they have to meet the minimum number of hours required by the employer. They also have to meet the minimum number of hours required by law according to the labor laws. So if they have worked, for example, 48 hours, they have completed, and they have extra time, they use that time to go at another private clinic. That's what we call part-time private practice. Now, I want to say here that it was introduced by government, obviously through this parliament, and I'll give a bit of details on that. But the reason why you approved it was that a long time ago, when medical doctors were going outside of Malawi for training, and they looked at the remuneration package you had in Malawi, none of them wanted to come back. So in order to encourage them to come back, and when they come back to Malawi, so that they can be retained in the system, whether private or CHAM or public, this was started. It was an essence of retention of staff. Honorable members, I can give an example. When we look at our register at the Medical Council, we only have got 3 cardiologists in Malawi, only 3. And what happens is, for Lilongwe, there's only 1 cardiologist who is based at KCH. So when you have 1 practitioner, and usually most of them, they look at the money that they get paid at the end of the day. If they were only to be depending on the salary, they cannot even manage to send their children to a good school. So during the part-time, they are allowed to go to work elsewhere. It has been a retention strategy. In Zambia, it's the same. Actually, the whole region is the same, even in Europe. So before it happened here, there was a team that had to do a benchmarking to see how it could be done in Malawi. So it has been a tool to retain staff. Honorable members, every year we are having 300 practitioners who are leaving Malawi. If part-time private practice is completely stopped, this number is going to go skyrocket. And the chances are there will be very poor services available to Malawians because most of the experts might leave. So that's one essence that has to be looked into. That has happened. Research has shown countries who completely banning private practice, people have left to go for greener pastures elsewhere. The good thing about private practice is improved access to services. Sometimes there are so many other big hospitals which have the resources, but they don't have human resource. So if the ministry allows their practitioners to go there, sometimes they will allow them to offer the services using resources, for example, at that private facility, but just using the hands that is coming from either another CHAM facility or from the public service. And it has also improved patient choice. Now, that is not to say that private practice doesn't have problems. It has huge problems. And before going to those problems, the Medical Practitioners and Dentists Act, Section 38, that's where now it says that in order to retain the staff, the government through parliament said practitioners might be allowed part-time to go and work in private. The Medical Council just doesn't give the license without any restrictions. Honorable members, firstly, there has to be a letter of application by the practitioner. Secondly, the employer has to allow them. In fact, I want this honorable house to be aware there are other employers who don't allow private practice at all. If the employer doesn't allow private practice, the medical council doesn't give a license to their employee, because in the regulations, this was a control. For example, we know CHAM facilities, some CHAM facilities allow some of their employees to practice in private, whilst some CHAM facilities do not allow. As long as the employer has not allowed them, then the medical council doesn't license. That's one element and the control that is there. And if it is someone who wants to participate in full-time, we require a letter of resignation or a letter that they were fired from their employer, and then only then they are allowed in full-time private practice. And then they are also assessed for eligibility. There are other practitioners who are not allowed for private practice if their behaviors are not correct, and we have documented evidence, but also their experience is inadequate. For medical doctors, they have to work for a minimum of 2 years. For clinical officers, they would have to work for a minimum of 6 years. So that's how we regulate. And lastly, there are practitioners who are allowed to own clinics, okay, even though they are employed elsewhere. Now, coming to how this can be managed, we think that there has to be a balanced approach. The way the regulations are and the way the Act is already is providing so many safeguards so that people don't just start private practice on their own, but their employer is key. Practitioners' working time at their primary employment, it has to be tracked. I think that's the element, first element. Second element, there are disciplinary processes already for those who violate private practice. Already at the medical council, when we receive a letter from an employer that this one is not adhering to the regulations, we invoke that license. So it is taken away and they are no longer allowed to practice in private. Also, as I said, the employer can decide. Even the public system can decide to say, we don't want our practitioners to be doing in private. Because ultimately, that letter of authority has to come from the employer. In this case, either the Director General, but it always has to pass through the Ministry of Health. So if the public decides, then the Medical Council will follow through. There will still be private practice, but not for those ones that are working in the government. So it doesn't need a law. We already have safeguards that can allow that to happen, because as every employer has got a right on managing their employees accordingly. And the other element is on ethical and professional conduct among those who are involved in private practice, but also there are some issues of increasing remuneration. If remuneration is increased, some of them would automatically stop. And I want to let this house aware that we have received over, I think, 200 practitioners who have ceased doing private practice on their own, making a decision on their own. So those are the safeguards, but a balanced approach really is required, because others do private practice very well, and they are some of the most harding workers wherever they are employed, whether it is in the government or it is in CHAM. So whenever we take this off, we'll be punishing all the very same way. So there has to be a balance of holding those accountable accordingly, but those that are also doing well to be held accountable.
All right, thank you. I think in short, what the doc is saying is asking the committee not to undertake the legislative processes that ACB asked this committee to undertake. Just to review the act that you have mentioned here. We go to Nurses Council.
Thank you very much, Chairperson and honorable members. I think I'll first take the question from Ncheu. Yes, Ncheu.
Ncheu Central East. It's Ncheu Central East.
Ncheu Central East. Thank you very much for your questions. Let me first of all mention that when it comes to nursing and midwifery regulation and registration, we have level 1 and level 2 of our professionals. Level 1 are those that are on professional status. These are nurses with a bachelor's degree going up. Level 2, we have technician, and these are with a college diploma going below. So CMA, community midwifery assistant, because there was a mention in the question about training for 1.5 years or 1 year. It means that's about CMAs. So, Chair, CMAs came in Malawi as a replacement of traditional birth attendants. That was around 2012, 2013, when maternal death was just very high. We were at 60-75 per 100,000 live births. And in neonatal death, we were at 47 per 1,000 live births. So government made a decision. How can we make the services accessible? That's why we introduced the CMAs. And as Malawi, much as we needed to domesticate our interventions, we also have to be relevant to international standards. So somebody has to be trained not less than a year to be called a midwife, all right? So that's why these community midwifery assistants were introduced, were actually trained at, within that period of time. And one of the reasons to have these CMAs deployed in the rural areas or the peripherals, the way you put it, the government of Malawi was also looking at what we call the 3-delay model. What are the delays? What factors prevent pregnant mothers from seeking healthy care? So there were issues of delay in decision making and delay in the distance, the distance issues, longer distances, as well as delay to be given the care. Now, most of our mothers are in the peripheral areas where we have all these problems. Now, that is one of the reasons why the CMAs have to be deployed to the peripherals or to the distant areas of our country. So I just wanted to mention that why the CMAs are often in the rural areas. Now, the other question was about confusion between a registered nurse and NMT. Why maybe when it comes to salary scale, they are on the same level. You are right, Honorable. As Nurses and Midwives Council, the decision that was taken was to phase out the registered nurse, this one with a diploma, because we also have this NMT, nursing midwifery technician with a diploma, and this is a college diploma. Diplomas that are obtained in most of the charm colleges in Malawi and Malawi College of Health Sciences. So the decision we took, because of that confusion in terms of starting point for salary and what have you, we said, no, let's have this cadre phase out. And that was also in line to straighten the kink in terms of career progression. Because when we are determining the qualifications, remember, as a regulatory body, we are also doing this in liaison or in collaboration with universities. So universities also have their criteria to admit somebody into the system. So we wanted actually to make sure that we just phase this out. Then we have the NMTs that will be obtaining the diploma from the charm colleges. Then we have BSc nurses that are in the university colleges and that sort. So that's the intervention that was put to address the problem. That's about I think the questions that came from Cheu, sorry, Chair, South.
Cheu Central East.
Cheu Central East. Then I'll progress to Mzimba. Is it Mzimba Verekezi? Yes. The question was about why is it that we are not including, or what is that we can do to include civil society groups in our regulatory framework. On that one, our act, this is the Midwives Act number 16 of 1995, provides, there's a provision in the composition of the council to have a representative from society. So we indeed have a representative from the society in the decision making processes of the council. And not only that, I talked about some of the interventions that we do, like dissemination of our regulatory services. We make sure we invite civil society groups for them to come in and play their role in terms of sensitizing the masses for any nursing or midwifery regulatory services. So that's what we basically do. Even in the reporting of cases, we empower in terms of information sharing the civil society groups that in the Act, there's a provision that should you see violation of nursing and midwifery service provision, report to the council. So they can direct the report to us as a civil society. And we work with Impeni and the like in this regard. I think the same question was also kind of reflected by Doa Chair. Yeah, so it's the same thing that our Act provides for inclusion in the composition of the council, a member from society. And we also involve them in the issues that I've also alluded to. So, Chair, that's the question that we address to NMCM. Thank you, Chair.
Thank you very much. We go to the people of Chitipa North.
Thank you very much, Chair. You also recognize the SH and all the presenters in this room. Thank you very much for granting the people of Chitipa North constituency to ask 2 questions. The 2 questions goes to the Nurses Council and Midwife in Malawi. We had a consortium of journalists some few days ago, and also the CSO who submitted, in their submission, they highlighted the exploitation of women, especially in maternity wards, through cohesive demands that are made. And looking at that, how does the council ensure that there's accountability when the nurse, midwife, they condition care on the official payment and the official payment during the labor and delivery? So how is the council ensuring this, that there's accountability on this kind of behavior? The second question is about, we also had the ombudsman yesterday, and in their presentation, they reported that there's weak comprehensive resolutions mechanism, especially in the hospitals. And you also highlighted that there are some delays with the ombudsman in your presentation. So how does the Nurses Council coordinate with the hospitals integrity committee that is available in the hospitals, and also with the ombudsman to ensure there's disciplinary outcomes that are there, consistent and also transparent, and also to reduce the delays that you mentioned? Thank you so much, Chair. I stop.
Thank you very much. 2 questions to Nurses Council.
Thank you very much, Honorable. Chitipa South?
Chitipa North.
Chitipa North, the opposite, sorry. Indeed, as Nurses and Midwives Council, we have held cases of nurses or healthcare providers demanding some sort of payment for patients to be taken care of. We have heard that. You know, the way we operate is very legal in nature, because we have had instances where when those that are defending themselves, in other words, they are responding to a case, they demand that there must be somebody who has complained to the Nurses Council. So in that regard, as we speak, as Nurses and Midwives Council, we have just heard, we haven't received a complaint, officially receiving that complaint that, okay, I had this, then how can we redress? So that's the situation. But we are saying we can't just sit and watch as a regulatory body. What is that we can do to navigate so that, because it's really disheartening to see visibly poor client coming in the facility, a health provider like myself demanding even 20,000 to be on the list to theater. It's inhumane. So we are working on that one, but we are also sensitizing the society that there must be a formal complaint for us to follow the legal procedures when it comes to addressing complaints. So that's what we are basically doing. On the coordination with the ombudsman offices at the health facilities, indeed we have challenges. I happened to attend a meeting of stakeholders on the same. I remember minister was there, and the agreement was that because the composition of those who man the ombudsman office at a health facility, they are of low cadre. What I mean is that sometimes they fail to report a case that is to do with a medical doctor, a colleague for that matter at that facility. Maybe they are not very courageous enough to report that case for maybe a DNO or a senior person at that facility. The discussion was possibly maybe we should attach this one to quality directorate of the ministry so that these reporting issues are straightened. There's nothing like I fear to report about my senior or something like that. So that's what we are doing to make sure that clients access our services regardless. Chair, that's what I can actually put forward as a response to their question. Thank you, Chair.
Thank you very much. Reaching this far, we hand over to the SH to respond to some of the questions raised, and of course, your final remarks.
Thank you very much, Chair and the committee. There were a couple of questions that were directed to the ministry. I mean, just to mention, Chair, the one regulator that is not here, the Health Service Commission, will look at conditions of service. So none of the entities that are here talks about conditions of service of staff. The Health Service Commission is one that is mandated to hire and fire and look at conditions of service. The issues that have been raised will be presented to the Health Service Commission, Chair, on the remuneration. In fact, the process has already started. There's already a draft review of conditions of service for healthcare workers. Only that most of the members of the previous committee, their time has expired this May, and there's a new commission that is being formulated. Secondly, the various entities are talking to various cadres within the sector, but also infrastructure or firms. So the Medical Council has a mandate on clinics and other healthcare providing facilities, PMRA, pharmacies, and licensing the same. It is noted, Chair, that in terms of premises, some of the owners of the premises are not themselves professionals, but they may recruit a professional. Sometimes that gives a little bit of problems. How you criminalize the entity. So that's also one area that would have to be looked at when you're looking at institutions. There were a few questions, Chair, on the SCB. I'll start with SCB. They mentioned 35% of medicines are diverted or stolen. We surely would need to get to be closer to SCB to understand that magnitude. Yesterday we did acknowledge that there's theft. but is it 35%? Is it 30%? Chair, we know where large volume medicine movement is. That knowledge maybe SEB has, but my office has. We know where large movement of medicines takes place. The challenge sometimes we have is if you know, there are well-wisher Malawians, Chair, that give information, accurate information. Sometimes the challenge is how do you move immediately? They will tell you that today there have been people from most of the neighboring countries are in country. They are meeting at place so-so, and they're transacting. But my office doesn't have cash, because you need to move immediately. And then you have to have a system that really can stamp on that. Let me just mention, Chair, that the previous time I was in office, in 2019, the president assigned an officer, even from MDF, directly to deal with this issue. So we know. And we saw the changes. We could track them. The only challenge MDF had was they don't have prosecutory powers. Prosecutory powers are not with Malawi Defense Force. But the information is there. The National Intelligence Service shares this information. So it is there. I think it is issue of what is the best way we can nip. I mentioned, Chair, yesterday, the case that has just concluded. Now it's no longer a court case, so we can discuss it, of a foreigner who probably the biggest buyer of medicines within Longwe. People may not know what has gone down to get to that level, but I mean, my auditor was mentioning where our challenges are. Fortunately, the Director of Public Prosecution is taking that case up. So we can't leave this unattended. We managed to do why can't we do this one? I think it requires really commitment, and it can be done. So the 35% we'll chat with SEB, but we also need to get a system that responds on time, and gets these issues concluded. As much as possible, Chair, what we are requesting on the legal side is custodial sentence, not monetary. And was custodial sentence is what we are requesting for us to nip this. I think we've tried, Chair, to meet the SEB and Ombudsman, and in fact we created a forum for the Director, SEB, and the Ombudsman. I created it. It was on the same issues. I will contact them because the issues around patient interface with the system, which the Office of the Ombudsman is. By the way, the Office of the Ombudsman, or the Ombudsman in Health, started in 2018, 2019. And who started it? The Directorate of Quality Services. So when the Council is talking about reporting system, it started with Quality Directorate, of course. And then we invited Ombudsman. Yesterday, we talked about the independence of that office and whether indeed it should be a fellow healthcare worker or indeed Ombudsman should have its own designated personnel. I think this is an issue that was on the table to be looked at. Those issues around the tracking system of medicines. Chair, the biggest buyer of medicines in Malawi is Central Medical Stores, the single biggest buyer of medicines. So if you're looking at large volume medicines moving in hospitals, it is Central Medical Stores. Let me just mention here that yesterday there was a posting on social media around some drugs that are in in South Africa, at Bay Bridge, those are not hospital medicines. We don't keep mandrax. If you read that article, you don't keep mandrax in hospitals. We don't keep that. So that is not anything to do with hospital medicines. But, Chair, there are some recommendations. First thing is, in terms of the digital movement of medicines or tracking of medicines. So from central medical stores to our district hospitals, we're using the Open LMI Logistics Management Information System to the district hospital. Our challenge has been supply to the health center. We've not reached that. So that's where the gap is. So if there any misses could be there at that time, at that point, tracking to health centers. Previously, we used health advisory committees that when a lot is arriving at the health center, then the health advisory committee has to ascertain medicines are there. And then I think once they are there is how do you control movement of the medicines at the health center and health facility. There's a 3-log system, it should work, but it has got its own limitations. The area that is still a gap also is, one other area that is still a gap is now the medicines have arrived at the pharmacy. How do you know that the medicines have really gone to patient A, patient B in the ward? So we already have within the system what we call EHIN, Electronic Health Information Network. And many people were trained. Many people were trained. What we would want our regulator, especially PMRA, to emphasize on is that our pharmacists also have to embrace this digital. Our people need to embrace digital space, digital systems. In some cases, we've seen some resistance, Chair. Not all cases, but in some cases, we've seen some resistance. I think it can help us track the medicines at facility level. At ministry, Chair, we now creating a logistics management unit because that interfaces with what is happening at central medical stores, and that is now quite advanced, the discussion on that, and it will see the light of the day in the next few weeks. Central medical stores, the tracking system of the truck that is carrying medicines is there. Next thing that we are looking at is embossing some tablets and medicines. Embossing means that if you have a tablet of Panadol, there should be engraved that there is CMST. Because then if you see that tablet in any other place other than a government facility, then it's a stolen medicine. All right, so some of our suppliers have already given us samples of what that would do to procurement is another question. Because now if a supplier is not able to emboss, should we take them? So that's another side that we need to be looking at. But we could say that all pre-qualified suppliers to central medical stores for medicines, then this should be a must-do to emboss where we can. Not all medicines can be embossed, but the majority of what we need can be embossed. And indeed, some of them have already given us samples of embossed medicines. I would say that in terms of final cases that are done by all regulators, all the 3 regulators, they shouldn't stop at keeping the records to themselves. All of them should be shared with Health Service Commission. He is the employer. So whether you've given 1 year, you've given a warning, you've given whatever, Health Service Commission needs to have a copy, because they also have their own hearing. So that is a must. So if I go to those places and we don't see that, then there's also underperformance of that institution. So it's a must. When they're sending to SH, all of them should go to SH, copy to Health Service Commission. Because then we can look at the hiring and firing side, Chair, for those that are the professionals. I thought, and then, Chair, we are asking Parliament to allow all these institutions, including Health Service Commission, to disclose the disciplinary findings. I think that if it's not appearing in the law, we can really review. But if it's not appearing, or if Parliament, I'm not sure how you would do it, but we need to start disclosing the final determinations on the disciplinary cases, either for the suppliers, facilities, hospitals, and the individuals themselves. I think we need to look at that. There are some cases that are still pending, Chair, and I think they probably are not yet for public consumption at this point. Thank you very much.
All right. Thank you very much, SH, for the interaction that we have had. Honourable members, ladies and gentlemen, we've been meeting in this place since Monday, and SH has appeared before this committee 3 days. He has led the teams from the ministry. This is the time he is appearing before this committee. This is something, as a committee and of course as a chair, we need to commend and applaud the SH for the commitment and dedication that he has demonstrated towards his work as SH, but also by ensuring that we need to provide as a country quality health services to patients, but also to achieve the universal health coverage. We have discussed a number of issues here. We started with Public Health Act, he was here. Been discussing the health financing, he was here. And today, he is here. It shows how dedicated and committed the SH is. I also ask you, the regulators, the recommendations given by the SH should be adhered to. Take heed of the recommendations, and we are here as a committee to work with you. I should also highlight here the cordial working relationship that is there between the Ministry of Health, senior management team, and in particular, the cordial working relationship that we have with SH. Every time we invite the members of Ministry of Health, senior management team, he's there. He's a busy person, but he leaves everything aside and chooses to be with us. This is why, as a committee, when you ask us to advance an agenda, the entire committee runs with that agenda, because we know that you respect us, and we also need to reciprocate the same respect that you give us. We will not let you down, because we serve the same people that the Ministry of Health is serving. There are a number of issues that we need to do as a committee, and we have lined up a number of activities ahead of us. Very shortly, we'll also be inviting you. We are in discussion with the SH and other senior management team members of the forthcoming investigation, which will be robust, we think, because it is touching on a very critical subject altogether. We are looking forward to meeting you again in a very near future for that discussion again. Honorable members, I also want to thank you on behalf of the Secretariat for the dedication that you have also demonstrated starting on Monday. No one has shown the symptoms and signs of withdrawal. Thank you very much, and may God bless you all. But before we dispense SH and your team members, we have refreshments at the back, as we always do. Please join us as we partake the refreshments. May God bless you all. Thank you very much.